Okay, welcome guys. Hello everybody. Thanks for joining us. I'm Daniel Lawrence and we've got Mike Grice here as well. And we're here for our weekly clinical chat. And this week we're looking at acute lateral ankle sprains and the rehab journey. Mike's going to start off and then I'm going to take over from Mike and we're going to have a chat about what we do and the research behind the current approach to this problem. Before we start, I just wanted to mention a couple of things by way of raising awareness. Firstly, we have a webinar next week. It's a live taping webinar and it's going to be split over 4 sessions and it's the equivalent to a full day's taping seminar. So it's not just a free webinar and it's not a substitute. It is a full course and there's only going to be 15 places on the course. There are no longer 15 places left. I think we have about 7 places left. And it is a full qualifying live interactive taping webinar. So if you're interested in doing a full course at the moment, then there's still places to sign up to that webinar. If you want more information, have a look on Facebook or of course have a look on the RockTape UK website where you'll find the details, find out more information, and of course you can ask questions. I'm involved in organizing it and Mike right here is going to be your tutor. So if you have any questions, please direct them towards myself or Mike. The other thing is tomorrow at 8 o'clock, I'll be on Therapy Expo's Instagram channel, live at 8 o'clock talking about shoulder rehabilitation. And I'll be looking at whether you can get away with just giving patients one exercise when they're suffering from rotator cuff tendinopathy, commonly known as impingement syndrome. Right, that's enough for me. I'll hand over to Mike to make a start looking at acute lateral ankle sprains. Go for it, Mike.
Thanks, Dan. Thank you, and welcome everybody. I see some familiar names there. So I'm going to be focusing on acute lateral ankle sprains, and this is a I think Zach's after a link for the course. And this is a talk I did at the Therapy Expo, I think it was last year, and just added a few bits to it just to update it for this evening's chat. So this was the reason why I chose the talk when I did it at Therapy Expo, and it was because of a systematic review in 2018. So said 40% of all traumatic ankle injuries occur during sports, and despite the high prevalence and incidence of lateral ankle sprains, only 50% of individuals who incur them seek medical attention. So there's a large proportion of individuals who sustain these lateral ankle sprains and they will develop chronic ankle instability. So we're going to go through the rehab journey from kind of when they come into clinic, what kind of things to look for. I'm going to do a little bit of an overview of anatomy as well, just in case people haven't looked at the foot and ankle for a while. And then I'm going to hand over then to Dan to go through some protocols for rehabilitation and some exercise prescription. So that's the plan for the session. If anybody wants any links to any of the papers that I use, then just pop the details on the chat box or in our Facebook group, and I'll be happy to pass those on for you. So some of the risk factors that you need to think about with ankle injuries when looking at sports people is intrinsic and extrinsic factors. So we've got intrinsic to do inside the body, and then extrinsic, usually to do with the sport itself or the playing surfaces, the equipment that's used, those kind of things. So intrinsic wise, one of the risk factors was limited dorsiflexion, reduced proprioception, reduced single leg balance, and reduced strength. And some of those things Dan's obviously going to cover to try and reduce the risk factors. And then extrinsic to think about is if you have athletes that come to your clinic that do these kind of sports, so any kind of jumping sports, climbing, which I thought was I hadn't really thought about climbing. I usually think about climbing with finger and wrist injuries, but there's a high prevalence of ankle injuries as well. Field sports as well, high prevalence of ankle injuries there too. If they play soccer and they play on natural grass, then that increases the risk. Any sport where they landing after a jump, and don't know the sport where you wear heels, but wearing high heels as well is an extrinsic risk factor. So that was one of the things that was in the systematic review. Okay, so I'm just going to have a quick revisit of the anatomy around the foot and ankle. So just switch screens a second. Bear with me a sec. Here we go. Okay, so we're going to zoom into the to the front of the ankle. So we've got the tibia, you got your talus bone here, and then the fibula on the lateral aspect. So the joint around here. Yeah, no problem. Joins around here are Marcus wearing heels every Friday night. Yeah, me on a Thursday, mate. So we've got the talus bone, and then the tibia and the fibula, and the talus bone is like a dome. And if one of the injuries that you can get with, especially with football, because of the studs that people wear. If you land it in a dorsiflex position and then externally rotate the foot, because the dome of the talus is quite large, it can separate the fibula and the tibia, and you can get a syndesmosis injury. So the app that I'm using there is called Complete Anatomy. It's on the Mac, and it's available on the iPhone and iPad as well as Essential Anatomy. So it's a really good one. And then we've got I'll go into the ankle ligaments because that's what we're focusing on today. So I'm just going to pop some ligaments on here. So these ligaments in here. So this is your ATFL, so your anterior talofibular ligament. So it goes anteriorly on the front of the fibula. Goes from the fibula to the talus, and then we've got this one here, the calcaneofibular ligament. So it goes from the calcaneus to the fibula, and then just around the back, just add another layer. There we go. Might not be able to get to it because there's another layer of connective tissue, but you've got a PTFL as well, a posterior talofibular ligament. And all of those ligaments are the ones that we're concentrating on for my particular part of the session. So all these ligaments around the lateral ankle. Okay, just going to switch back onto the slides a second. Okay, so first few days then in clinic, or first few days when they present.
Mike?
Yeah.
What was that app you were using? People are asking that thing you had programmed looked awesome. What was that? It's
called Complete Anatomy. It's on the Mac. On the iPad and iPhone, it's called Essential Anatomy. Yeah. It's a really good one, really good. And it's got loads of layers. So you've got all of the nervous system, all of the blood supply, absolutely everything. You can take layers on and off. So it's really good. So if you get an lateral ankle injury into clinic, obviously it may be a sprain, but there are other things that you need to think of as well. So there's something called the Ottawa ankle rules, which we'll have a look at. You could have a high ankle sprain, which is a syndesmosis injury, which is what I was just talking about with the tibia and the fibula, where it can separate, especially with dorsiflexion and external rotation of the foot. It can open up the tib and fib away from each other. And you also need to check the other foot as well, because if the other foot is swollen, then it may not be to do with an ankle injury from a sports injury. It could be a systemic issue, or they've sprained both ankles. But it's something that you need to consider if the other side is swollen as well. So just going to have a look at the Ottawa ankle rules, just in case you've not seen those before. And this links nicely into, just move us over there, links us nicely into some of the things that Dan was talking about last week with sensitivity of tests. So this set of tests, if they are all negative, so if there's no tenderness on any of these points and they're able to fully weight bear, then it's nearly 100% sensitive. So you can pretty much, damn it, rule out any kind of fracture of the malleoli or the midfoot. Okay, so this is a really good test to use to rule out a fracture. So what you do is you palpate these points. Just pop this on here. So we've got point A, point B there, point C here, and then point D here. Okay, so we're having a look at the posterior edge or tip of the lateral malleolus and the medial malleolus. That's point A and B, and you palpate those the edges of those malleoli, and then you'd also palpate the base of the fifth metatarsal and the navicular. Okay, so if all of those are pain-free, then it's unlikely that they have a fracture. Okay, so it's something that you can use in clinic really nicely to include in your testing to rule out any kind of fracture. So that's a useful test to use. So something early stage, something you might have seen on first aid courses that you've done in the past is Rice. Okay, there's been a fair bit of debate about Rice over the last at least 10 years, and in this systematic review, there was no evidence that Rice alone, so Rice on its own, or cryotherapy or compression therapy on their own, has any positive influence on pain, swelling, or patient function. Okay, therefore, there is no role for Rice on its own in the treatment of acute lateral ankle sprains, and that's really important and something that we'll kind of add on to in a sec. So that was from that systematic review again. And then something that came out in 2019, I think it was about this time last year, about April last year. Blaise Dubois did a blog on the BJSM website, and I've popped the link down there again. If you want it, just let us know. And he talked about peace and love rather than Rice. Okay, so we want to protect the injured area, elevate it, avoid anti-inflammatories, compress the area, and educate the patient. So educate them on pain, the kind of timescales of tissue healing, that kind of thing. And then we want to load it. We want to give the patient optimism, so work with them, work on a plan, and then vascularization and exercise kind of join together, really, because to improve the vascularity of the area, you need to move. And that's something that Dan's going to cover a little bit later on. So we're going to have a look at this kind of peace and love concept rather than the Rice, which was what I certainly learned a long time ago. So non-steroidal anti-inflammatories may be used by patients who have incurred an acute lateral ankle sprain for the primary purpose of reducing pain and swelling. However, you should take care in their use as it's associated with complications. And I mentioned that it's associated with especially gastrointestinal bleeding. That was on my OSCE presentation last Friday. And it may suppress or delay the natural healing process. So part of the process is inflammation. And if you're reducing inflammation through non-steroidal anti-inflammatories, then it can delay the healing process. So it's just something to consider when you're dealing, especially if you're dealing with athletes. So I'm an osteopath, so we were taught joint mobilizations all the way through our training. And if you use them on their own, you get short-term relief. Okay, and that's widely known anyway. So we need to combine them with other forms of treatment. And the systematic review recommends combining mobilizations with exercise therapy, and that enhances the efficacy of the joint mobilizations, and therefore they're advised. Okay, so you can do joint mobs. Obviously you would tailor them to the individual. If someone had an acute lateral ankle sprain, you don't really want to be HVTing that talocrural joint, but you can do gentle mobilization around the area as long as it's combined with exercise therapy. Okay, so that's really important, is the two working together. And then functional support. So something that I'll cover when I do my the taping course. I do this when I teach FMT1 as well. Some people ask about lateral ankle sprains, so I show them this taping technique, and I'll show you in a sec. So the use of a functional support for 4 to 6 weeks after the injury is preferred over immobilization. So we try not to rest too much now. We want to protect the area and keep it moving as best we can. So the use of an ankle brace shows the greatest effects compared with other types of functional support. So I'll just show you this. This is something that you could use. Turn the sound down. So maybe not something that you could do straight away if someone's got a very sore ankle, but certainly down the line a few days or a week afterwards, But here we've got a J hook around the ankle,
Right.
with a lot of tension through. Yep.
The sound is playing.
Yep.
It's really great
Oh,
music,
is it?
but it's can't hear you that clearly.
Okay. I don't know how to change that. Okay, I'll stop that. It's not playing on my end.
Oh, maybe just for me then. I don't know.
Yeah, just for you, mate.
Yeah.
So
Like your high
you wrap.
heels comment.
So you wrap the tape around the from the medial aspect around to the lateral aspect, and put quite a lot of tension through that lateral aspect, so that the foot can't go into inversion. Okay, so that calcaneus can't invert, or it's limited anyway. So it's really good for the patient, because they can feel quite comfortable with that on. They feel very supported, and then you can apply a heel lock. I'm going to play the video again. Apologies for the music. Fine for me. Okay, so I just pause that there. So we can apply then a heel lock around the back of the ankle and over the mid part of the foot, and that locks the calcaneus in place. Well, figuratively locks it in place. So it just provides that ankle with a load of stability, so that we can then do some exercise. We can do some exercise therapy then, and they don't have the fear that they're going to re-injure that ankle with the mechanism, which is that inversion sprain. Cool. I'm glad you enjoyed the music, guys. Okay, so that's a type of functional support. Obviously, there are lots of them out there. And then obviously one of the things we've mentioned quite a lot is early exercise. So it's advised to start exercise therapy, especially if you're working with athletes, as soon as possible after the injury has occurred. Okay, so and Dan's going to go through those with you in a sec. How much tension? So on the Christian asked about how much tension on the tape. So on the green piece of tape that went medially to laterally, probably about 80% as I go on the undersurface of the foot, and then over the lateral malleolus, I'll go up to 100% there, and then lock it in, and then no stretch on the end, because I want to limit the inversion movement on the ankle. Okay. So question from Marcus. I think Dan will cover those, Marcus, for you about the exercises from day one. So exercise therapy should be included into regular training activities as much as possible, as well as home-based exercise as well. So there was a real kind of shift in this review, and it was a review of around about 50 papers. So there was a lot of data that they used for the review to come up with these recommendations. And exercise therapy was one of the key things. So I'm going to pass you over to Dan, and he's going to talk about that.
Yeah, let's do this. So let me get my slides up here then, Mike. So I go to File, Share. It says it's sharing. Should come through in a sec. What I've done here, guys, is I have really tried to lock down what the most important parts of, or should I say, what the most important pillars are for ankle rehabilitation. And there's 4 things that we're going to look at, which will come up on my slides when they've uploaded in just a moment. And this is from a study where they looked at acute ankle injuries, and what things would determine a patient then transferring to more of a chronic ankle injury. An interesting statistic, okay, they just come up here, Mike, is that of people that experience lateral ankle ligament injuries, about 30% go on to experience ongoing dysfunction, ongoing problems. And in clinic, we probably see or probably assume that it's a much higher percentage than that, because of course, those 30% of patients are likely to present to us. So we certainly see a lot of people in clinic who have had an ankle injury and quite simply have not fully recovered from it properly. So I'm going to bring up my presentation now and start it, and it should come through. There we are. Right. So with the ankle, of course, ankle fractures are also common. The difference is about 8 to 1. So for every 8 inversion injuries that you get, every 8 soft tissue injuries, you're likely to get an occurrence of 1 ankle fracture. So you see a lot less ankle fractures than you do inversion sprains. We're focusing today, of course, on the inversion sprains. So I've looked at these couple of studies, evidence-based treatment and ankle sprains to chronic ankle instability, and looked at the pathway for dysfunction. And before I get into those 4 key pillars, the things that I wanted to look at here were, so just open the chat there. So the video and sound has frozen. Is it okay now, guys? Can you hear me all right? Can somebody just say yes or no? Mike, can you just ask that question?
Yeah, guys, if you could let us know if the video is okay.
Just wanted to check. Yeah, Peter says okay. Yeah. Okay, thank you. Right, I will continue. So Mike just spoke about functional support and exercise. They do provide better outcomes than immobilization. Well, that was from a study in 2002, but I think it's been known for some time that immobilizing inversion injuries was not generally a good idea, especially coming from an exercise and rehab background. Also, as Mike mentioned, with exercise, there's less risk of reoccurrent sprain. And again, I think that's quite a logical approach, something that we probably knew before the research was done. Also with exercise, you get reduced swelling, a faster return to work or return to sport, I should imagine, and balance exercises also reduce the rate of reoccurrence. Those are those research studies where I almost wonder if they really needed to be done. Otherwise, they were just kind of confirming what we already knew or considered to be kind of common rehab sense. So then we look at this study. Is there a new paradigm, a new way of approaching rehab for chronic ankle instability? And these are the impairments that will determine an ankle going from acute to chronic, or an ankle effectively not recovering properly. And the reason is this. If you look at these things here, range of movement, strength, balance, and function, what's missing is pain. Most people that have an inversion injury of their ankle will experience pain, and that pain will resolve over a number of days, and then over the course of a couple of weeks, it's usually cleared up. However, they will still likely have deficits in range of motion, likely have deficits in strength, which will continue for some time, if not indefinitely, have deficits in balance, and also overall reductions in function as well. But these things are not always apparent or detected by the patient. And if they feel the pain has gone, they may stop coming to see you for rehabilitation. So these are the impairments that you need to check for and fully rehabilitate in order to properly restore an ankle to full function. If we look at the first one, range of motion, the key range of motion is dorsiflexion. The research indicates that this is reduced to, as it says there, 4 degrees post-injury, so not very much. And we need about 10 degrees for walking, but 20 to 30 degrees for running. Now, if you think about someone who has restored, reduced pain and restored some dorsiflexion to their ankle, and they can walk without pain, then they can probably get at least 10 degrees of dorsiflexion. However, when they're running, if they can only achieve, say, 15 degrees of dorsiflexion, then they may be running in a less than ideal way. They may be running, of course, with a deficit and a dysfunction that could cause further problems. It could cause an unbalanced loading of tissues. It could cause a shunting of forces up to the knee, which we see quite a lot commonly. If there's reduced ankle range, it can affect the knee, particularly for patellar tendinopathy. So we need to work on restoring dorsiflexion. And I'll give you a tip. My favorite test for that is the dorsiflexion lunge test, which we spoke about last week, didn't we, Mike? You mentioned the dorsiflexion lunge test. So that's a great test because it's a test with good reliability, and you can also get the patient to do it themselves at home, and there's likely to get some good results, some reliable results that they can use to share with you. So range of motion, dorsiflexion, that needs to be restored to 20 to 30 degrees. Well, it depends on what the dorsiflexion is for them normally. So typically the other side, if that's not got a history of injury, would be your baseline. So you need to restore dorsiflexion to their baseline, or at least to 20 to 30 degrees if possible. If you can't do that, then you may need to look at footwear choices in order to help with the dorsiflexion requirements. Next, strength. When the ankle inverts, we are going to see a stretch and potentially a strain of the peroneal or fibularis muscles. But they're not the only ones that have shown strength deficits. The research shows the strength deficits are in all directions. And this indicates that the muscular inhibition is likely centrally driven rather than being determined by the localized muscles which have been overstretched. So when it comes to rehab strength-wise, you need to restore strength in all directions. It's almost as if you need to get the brain to plug back into the ankle again and engage in all of the movements and motions, even if it's just isolated or isometric exercise. We need to get the strength functioning in all of those directions. Then we come on to balance. Interesting thing in the research was that balance was reduced on both sides bilaterally, even though the injury was just on one side. So it's thought that in the early stages of an ankle injury, the balance deficits are more central. As recovery takes place, the balance deficit then becomes more focused on the side that was injured, as you'd expect. So working on balance generally is very helpful in the early stages of ankle rehabilitation, as well as the latter stages. And if we think about what influences balance, it's the inner ear, the vestibular system, it's vision, and it's proprioceptive input as well. And Mike's just shown you a video of taping, and we know that taping can improve sensory input. So taping is one way of improving proprioceptive input, particularly when it's when there's a deficit there. We can use vision to help improve balance as well. So we can do some visual exercises or even close our eyes, which makes the other balance systems have to work harder. And the vestibular system is involved with our balance at all times. So anything which challenges one or all of those systems will help to rehabilitate balance. And of course, if we're standing on the affected limb, then it's going to help to improve the proprioception from that area. Then we get to function, and the functions that they looked at in the study were gait and jumping. So we'll just focus on gait for now. There's, interestingly, and I'm not quite sure what this means from a rehab point of view, but it is something to bear in mind. There's increased inversion that remains through the stance phase of walking. So that, if you think about it, is going to put the foot at an increased risk of inversion because it's sitting in more inversion than average already as you put weight on the leg. So that may be one reason why we see a reoccurrence of inversion injuries after an inversion injury, is because for some reason the ankle is held in that in an inverted position. And you might think the body might want to protect itself and put it into more of an everted position, but the research indicates that it sits in more of an inverted position. There's also increased knee flexion as well. There's just some kind of offloading mechanism. And as with many functional research approaches, it seems that you can't just treat the deficits like the dorsiflexion loss or the strength loss and then expect that to restore the function. The function is almost has a life of its own and needs to be rehabilitated individually. So if there's a gait disturbance, you need to focus on rehabilitation of gait. So gait rehabilitation, and that can't be replaced with range of movement exercises or strength, which still have an important part to play. But when you add range of movement to strength and to balance, those three things won't equal a resolve of the function. The function needs to be tackled in its own specific way. So, yeah, that's the kind of key things that I wanted to speak about. I think when you rehabilitate gait, you want to rehabilitate it in the planes of motion. So we can think about the heel to toe rocker. We can think about supination to pronation as well. And we can think about the rotatory elements that are involved in normal walking actions also, just with the torso. So they are the impairments. They're the four pillars which need to be worked on. And simply seeing a reduction in pain is not enough and would leave the individual at an increased risk of future injury. So I wanted to try and make it as simple as we could. And this slide represents the key things that I wanted to talk about. And I kept the presentation short for that reason. We're getting towards our question time now. There's more stuff on the slides, but that was not necessarily for our session today. So yeah, that's it, Mike, from me on the 4 pillars. I think it's time for our bit of Q&A now.
Yeah, Chris Kitson has asked how much more inverted. That was the question. I'm not quite sure what it's related to.
Yeah, I understand your question.
Yeah,
it's a great question. I can't be sure that looking at the research, but it was only a few degrees, Chris. It wasn't a huge amount. It was only a few degrees. But when you look at what a few degrees at the ankle does to the shifting of the body weight higher up, then that few degrees becomes much more summated by its distance from the shift in our central weight distribution, if that makes sense. So yeah, it's only a few degrees, but I still think it's clinically relevant as well.
We've had a question from Russell Norton as well. So would inversion not be through because the ligaments have become strained and therefore in a more lax position? The injured area has no strength to maintain that strong, healthy position.
Yeah, I'm not sure why. The mechanisms behind it weren't detailed in the research. So that's a good reason why that might occur. The other reason I thought is that the foot may be unable to dynamically stabilize as well. And as a result, it may just be trying to fix itself in a safe position, a bit like what could be described as a postural lock, or a bit like when somebody locks their lumbar spine into hyperextension when they're doing a lifting exercise. The ankle may be trying to kind of lock itself into a position as a protective mechanism. And that protective position, when there's a co-contraction between the everters and the inverters, may be slightly more inverted than in a healthy ankle. So that's my take on it.
Really good. And then Dan Williams, who I noticed had a rather interesting bandana that he made this week. Not sure I'll be wearing his bandana. How about loaded gait training? Wouldn't you add load and weight to those exercises depending on their capacity?
Yeah, I can answer that. Do you want to take that one, Mike?
I mean, I guess it would always depend really on the individual and how they respond to unloaded initially. If you feel that if they could tolerate it, then and it depends on where they want to go to as well, what their goals were. Then I don't see why not.
Yeah, I agree. Yeah. Cool. Thanks, Dan.
And then Leanne, rough timescales for rehab. A good one.
Yeah. Well, it really does depend with the rehabilitation. If we need some rough timescales, I mean, for a grade 1 type of inversion injury, often you see some good results in a few days. I think it's important to start some form of strengthening engagement early on to reduce unnecessary inhibition and atrophy of the muscles as well. And I think a lot of that early atrophy is more centrally driven. So the research indicates that even imagining exercises, and I'm speaking the truth here, I'm not making this up, even imagining exercises without actually activating the muscles can reduce the strength loss that's associated with injury and immobilization. I'm not saying that we should do that with ankle injuries, but I'm saying that we can start to think about literally and engage the muscles as early as possible within rehabilitation, and start moving things really as soon as we can within rehabilitation. And also to maintain assessment over the first few sessions, just to make sure you haven't misdiagnosed an ankle injury as a higher ankle injury or a fracture, for example.
I know Claire Minchell mentioned that she might be on this evening. So I don't know whether there's been any research done, but she's done, I think she's done some herself, or she mentioned it on a course I did with her about a crossover effect. So if you've got an injured limb, by working the uninjured limb and not doing anything on the injured side, you actually maintain some of the strength or improve the strength without doing anything to that injured side. Just purely by exercising the uninjured side, you get benefits too. So
yeah, I find that amazing, don't you? I mean, I've read a few
isn't it?
studies, and Claire's done one. Claire Minshall at Back to Sport did a brilliant blog on this. So look that up if you want some more info. But yeah, I find that amazing, Mike, to get our heads around ourselves. But then I think the biggest challenge is to get patients to buy into it
Yeah.
and not think that you're some kind of crystal healer.
Yeah.
Sorry if you are.
I think Marcus mentioned right at the beginning as well about isometrics and isotonics in the early stage. And I don't know what your thoughts are, but again, I think it depends. I would usually start with just isometrics initially.
Yeah, me too.
See how they tolerate that, and then move into isotonics. If because generally, I remember when I was very first told, I was taught that we had to get the range back first. That was one of our key goals. But then I found kind of in clinic that the working on the strength actually helps improve the range. So rather than waiting for that box to be ticked before you move on to strength work, introducing it early really helps the recovery of the range of movement as well. Is that what you found?
Yeah, absolutely. And based on what we were just talking about, I see Claire Mitchell's popped up on the comments there. Hello, Claire. Thanks for joining us. And Claire mentioned regarding the crossover is that you need to get the effects of crossover, it needs to be high load and low repetitions to get the most effects. So just kind of willy-nilly flapping the other ankle around is not going to give the stimulus, but it needs to be a proper stimulus to get the effects. Thanks, Claire.
So we've got Emma said, so if peace and love is the way to go over rice, does that mean my rugby lads getting drunk, which means they don't need ibuprofen, and then optimally loading in the bar as long as they don't fall over are doing the right thing early on in rehab? I don't think you're going to stop them, are you?
No. Oh, brilliant. Who was that from?
That was Emma Turner.
Oh, okay. Thanks, Emma. That's brilliant.
Probably, yeah.
That's the reality, isn't it, Mike? I mean, you've got to take the research and then applying that into clinical practice and applying that into the reality of your work situation is something which is often missed in the research studies, and is something that's obviously for discussions like this. So yeah, it's a great,
really good. Yeah,
look at real life.
Joe Stewart said, what are the best exercises for the once the injury has become chronic, so several months to years after the original injury, if it wasn't treated properly originally? That's a good one. What would you do there, Dan?
Yeah, it was a good question. Sorry, I missed that. Which one was that?
So Joe Stewart, best exercises for once the injury has become chronic, so several months to years after the original injury.
Yeah. So the best exercises, well, I would look at these pillars and then identify where the deficits are. And then these are some of the things that we'd look at. So in terms of restoring dorsiflexion, the combination of immobilization with an active dorsiflexion is a great combination. And that could be using the therapist mobilizing and then the patient moving at the same time. So an active mobilization, or you could use a belt or one of those mobility bands to create that effect in a gym or home environment as well. Restoring strength, you've just really got to provide a decent strength stimulus. So you want high load, low reps, because that's the most efficient way to improve strength. And you don't want to mess about. You just want to get them loaded, and that will work if you keep doing that over time and allow enough time for adaptation. When it comes to restoring balance, well, there's a whole host of things. Really, anything which safely challenges balance is going to improve their balance. If they're not challenged by the balance exercise, then it isn't really a balance exercise. If they keep falling over, then that doesn't really meet the safety criteria. Some people say, or there's been some people sort of suggesting that you shouldn't use wobble boards, and there's been a bit of an anti-wobble board brigade. But I think now people have got bigger things to worry about than whether you should or shouldn't use a wobble board. Most patients don't have a wobble board at home, but if they did, why not use it? Restoring gait as well. I would break this down into step 2, step through. That's the stance phase. So step 2 is the terminal swing to early stance. Step through is the stance phase, and then step out is the as it says, it's the push off phase as well. So where they have a deficit, you can break gait down and work on that part of the gait pattern as well. Then finally, you need to think about where you go with your rehab. Some people may just need to do some low level strength training and then they're back to normal function. That's fine. But others may need to be pushed considerably and tested more specifically to make sure that you've really got back the strength and function that you're looking for. So not just the maximum voluntary strength, but also things like the speed of the muscle contraction as well, the rate of force development, and also muscular endurance, things that could be looked at in more detail. So that was a bit more detail about how you can actually achieve those impairments as well.
Brilliant. Thank you, Dan. Really good. Some good questions tonight as well. So we decided to do ankle rehab this week, and born from a little bit of a discussion we had on the previous webinar that we did. But we're really keen to be guided by you guys. So if there's anything you want to discuss, you want us to discuss, then we're quite happy to do that. So if you got any ideas, otherwise we'll come up with ideas. We've got plenty, but we'd like to be driven by you. If there's anything in particular that you want to cover, then please let us know. And also you know that I'm doing my taping course, my online course. So we're doing it where we're creating a very small group and creating a Facebook group around it as well, so we can use that group to do videos between each other. So we wanted to know as well if there are any courses that you want to see that you think could maybe be able to be delivered online as well. So if there's anything in particular that you want to see that you haven't yet, then please let us know. We'll be happy to put those on.
All right, there's a few suggestions coming here, Mike. So yeah. Thanks. Thank you, guys. Thank you for joining us.
Nice one, brilliant.
All right.
Really good. So we'll collect all those. Thanks, guys. That will keep us going for the next year.
Did you record this, Mike?
Yeah, all recorded. Yeah. So
we'll get it up on the Physio channel for people that have missed it. So obviously let people know if you want to refer them to the Physio channel on YouTube.
Brilliant. Thanks, everyone.
Nice one. Thanks, Mike.
Cheers.
Thanks, guys.
See you, mate.
See ya. Bye.
Bye.